Welcome, my name's Kayleen Knox. I work in Comcare's Provider Frameworks and Return to Work team, and I'm very pleased to be hosting this forum today on Safe Pathways Back, supporting return to work after bullying-related injuries. We're recording this forum, but only myself, the slides that you see, and our presenters will be in that recording. So here are some housekeeping matters. The Q&A function is available to post your questions for our presenters today, and the chat function is open as well. If you're using that chat function, please do remember to keep your comments respectful and constructive, as you always do. And please don't post anything that might identify an employee or a particular case. And yes, we will have a poll as well, an MS Teams poll shortly. I'd like to acknowledge the Yagara and Turrbal peoples, who are the traditional custodians of the land from which I am speaking to you today. I also acknowledge the traditional custodians of the various lands on which you are all working from. I pay my respects to elders past and present and acknowledge the contribution Aboriginal and Torres Strait Islander people have made and continue to make to these regions, and I extend that respect and warmly welcome all other Aboriginal and Torres Strait Islander people who are present. I'd also like to acknowledge the expertise of those with a living or lived experience of disability, injury and mental illness, and recognise the courage it takes to share lived experience, particularly when that story involves distress, trauma or harm in the workplace. So today our keynote speaker, Jennifer Chate, will be speaking very honestly about a difficult period in her life. And we deeply appreciate her bravery and her generosity in sharing her story so that others can learn and find better ways to support recovery. But we also recognise that some of the things discussed today may be confronting or bring up strong emotions for our audience. So if anything we cover feels upsetting or overwhelming, please take care of yourself. Step away from the session if you need to and reach out for support afterwards. So there's supports listed there on the slide, and there'll be a selection in the chat as well. So do take care. So here's our agenda for today. I'll start with a Comcare update and then move into our main session on supporting return to work after bullying-related injuries. We're fortunate today to have two great speakers bringing both lived experience and clinical expertise to this conversation. So Jennifer Chate, an educator and founder of Cherry Tree Cooks, will share her personal experience and what helped her in her recovery. And then Dr Simon Kinsella, clinical psychologist and director of CP Consulting, will unpack the psychological impacts of bullying and provide practical trauma-informed strategies for safe and sustainable return to work. And then we'll have some time for a question and answer session. Okay, so that takes us nicely to our main session for today, which looks at one of the more challenging areas of rehab and return to work, as you know, which is psychological injury claims that arise from workplace bullying and harassment. As you'll see during registration, we asked a few questions about your experiences supporting employees with these sorts of claims to get a sense of what you find most challenging and how confident you feel supporting the employees in this situation. So here's what we found. In terms of confidence ratings, the responses were quite varied, from very confident to not confident at all. But interestingly, even the very confident case managers were saying, I want new strategies, tools, tips and ideas, which I guess is, just shows us how complex this area is and why we felt it was important to have this discussion today. So from the registration responses to the questions about the main challenges, you told us that what you find most difficult in bullying-related claims is not the rehab process itself, but navigating the distrust, the fractured relationships, and the fear that sit around that injury. But as we'll hear today, instead of being barriers to manage return to work, those reactions are the injury. And understanding the psychological injury, the hypervigilance, self-protection, the avoidance, perhaps the need for justice, the threat response, any and all of those things will make decisions about return to work pathways a little clearer, safer and more realistic. Then we can start to understand what safe actually looks like for employees who have experienced bullying and harassment in the workplace. And to help us ground this in real experience, we are very fortunate to have two speakers who bring both lived and clinical expertise to this topic. Our first speaker, Jennifer Chate, is an educator, entrepreneur and founder of Cherry Tree Cooks. She'll share her personal experience of workplace bullying, how it affected her well-being and recovery, and what made a difference in feeling supported and understood along the way. After we hear from Jennifer, I'll invite our second speaker, Dr. Simon Kinsella, who is a clinical psychologist and director of CP Consulting, to join us. Simon will unpack what's actually happening psychologically in these situations, how bullying can lead to injuries such as anxiety, depression, even PTSD, and how those symptoms may appear during return to work planning. We'll also share practical trauma-informed strategies case managers can use to support safe and sustainable recovery. Before we welcome Simon to this discussion, we'd love to hear your story, Jenny. If you are there and you could turn on your camera, welcome to the forum. Oh, you're there. Good. That worked. That's a relief. Welcome.
Thank you, Kayleen.
I'll start with a question. Just to start us off with your story. So can you take us back to when your workplace injury occurred and what was the situation? How did it unfold for you?
I'll start by saying I was 17 years an educator and I moved across different locations, and I was at this particular location for 5 years. My micromanaging manager herded 7 of us into a tiny space. She was really angry about tablecloths. She screamed and spat and shook, and I knew immediately that something was really wrong with me. So my hearing went muffled. I felt really dizzy. I felt like I was going to vomit. And I had a memory came to me, or it was almost a vision. So I could picture myself laying down. I was on a bed and I was looking across my bedroom at my brother, and my mother was attacking him. It was so clear, it was just about a picture. But the memory could have been true because my childhood was very traumatic and my mother had schizophrenia, so she was very violent, but I had no memory of it at all. I staggered out to my car. I passed lots and lots of people. I passed colleagues. I passed other people that I worked with, and everybody just looked at me. I made my way to the car. I called my husband, who sort of talked me down to drive the 10 minutes home. When I got home, I just went straight to bed. I felt really tired. I couldn't speak. So I had sentences in my head, but when I actually went to say them, they came out of order and they didn't make any sense to me. I was really, really scared, and I was immediately really paranoid. So even driving home, I just thought I was going to die. I thought there's going to be a car's going to hit me, something's going to happen, I'm going to die. The next day I called my doctor. So I have a really strong medical team around me. I called my doctor. He said this was a trauma reaction. I then spoke to my specialist, who's a psychiatrist, who said, Jennifer, this is a true memory. It is from your childhood. It basically has been protected for 50 years, and events of yesterday have drawn it out. That had a re-traumatizing effect. So that I returned to work. My specialist said that I could return to work after 6 weeks. We actually worked together very closely for that 6 weeks. So I did return to work. I drove into my work, opened the door, and my manager opened the door and she screamed in my face, "You need to pull yourself together." And that was it. I just went again.
Wow. Wow. Okay. Wow. What an experience. So sorry that happened. So, what was there any support for you that first time you went back to work, or what happened at that point when that's how you were greeted?
My workplace had actually immediately admitted liability, so they had no issues. The event had happened. It had obviously affected me, so they immediately admitted liability. But when I first went back, my colleagues didn't talk to me. So the people I'd worked with for 5 years didn't say anything. They were angry. There was no meeting or anything like that to say that I was coming back. They were surprised that I was coming back. So there was no support put in place, but there was no communication at all for both sides. So my colleagues didn't know what had happened. They didn't understand what had happened. I was normally really competent, or in their eyes, yeah, there was no support from my workplace. They just wanted me back. It was as simple as that.
Yeah. And did you stay that day, or what happened? You went.
It was a complete repeat. So again, my ears were ringing. I couldn't hear properly. I felt like I'd been wrapped in plastic. So I felt really hot, and I just felt like I was really I felt like I couldn't breathe.
Yeah.
My skin was clammy. I literally felt like I was wrapped in plastic.
Yeah.
I drove home again. I spoke to my GP. I spoke to my psychiatrist. Both said that this would be a longer journey back. And over the next 9 months, I really couldn't think. I couldn't speak properly. I couldn't put thoughts together. My husband, the indicator was when my husband would say to me, "Can you hand me the milk?" Because he makes a cup of tea every night. And I would hear the sentence every night. I'd hear the word milk, and I just didn't know what to do. And I was a food tech hospitality teacher, so everything was just so confusing, and I just could not get thoughts together.
Yeah. Yeah. And it sounds like your treating practitioner, your supports around you, they were very aware of what was going on. At what point did you realise the impact? Were you aware of it at that stage, of how serious that it was? More than just a return to a difficult colleague? It's a lot more than that.
I wasn't at first because I was really just really half conscious. Yeah. I just thought that I was very paranoid. I was very unhappy, sleepy. I realised that it was more of a problem as those hidden memories kept being extracted. So each time I would talk to my psychiatrist, he would give me more and more guidance over the memories that I was having. And the cruel thing about the memories that come out is that all stories have a beginning and an end. When these memories were coming out, it wasn't beginning to end, it was a portion. So that meant I didn't have the start of the story and I didn't have the conclusion. So, or it would just be the end or just the beginning. It was just chunks. And so it still didn't make sense. And that was really frightening. And still to this day, those memories don't make sense.
Yeah. Yeah. Okay. So was it at the beginning of that 9 months, you said the employer accepted liability, so you made a claim at that point?
Yes. So
I was going to ask, did you get help? Did you get some assistance?
The assistance came from the rehabilitation case manager. So am I allowed to mention who the insurer was?
Yes, that's fine. Yeah.
The insurer was Allianz, and the return to work rehabilitation was Altius. Allianz rang me 2 days after I left work, and they just really briefly tried to explain what was going to happen. Yep. They were very brief, although I had to put my husband on because I just couldn't understand what was going on. The rehabilitation case manager then contacted me the following day, and she was I credit her with bringing me back. I credit her with using, if she had have done anything wrong, it would have harmed me more. And she was absolutely incredible. So when we talked over the phone, she let me talk or try to talk, and she just gave really simple 1 or 2 word prompts. She said to me, so when she worked out that asking me questions wasn't going to be successful, we organised she was organising all the appointments for the specialists, so I had to see psychiatrists for the employer. She just said to me, you need to see a psychiatrist. I want you to be at this place at 9 o'clock. And like, do you understand, like, what time do you need to be there? I'd say 9 o'clock. Right. Have you got someone to write that down? Do you want to write that down? So she literally did one tiny step at a time as I needed it. So then I would go and see the psychiatrist, and then we'd do the very next step. But where her superpower was in the medical case conferences. So she had this paperwork, and at the top of it, it said something like return to work plan number 6, number 7, number 8. All I remember was the 6, 7, and 8. And it told me, it was in font that was about 80 font at the top. And I knew that I was making progress because it was going 6, 7, 8. I had no idea what was being said, but that's how I knew I was making progress. That's how limited my capacity to think was. Then there were tables that she did which showed this is how many days you'll return to work, but she actually had the table drawn out like a calendar. So she said, this is week 5, or this is the top week, we're now to week 5, you'll work this day and this day. The next one, you'll work this day and this day. So she didn't write it out, she actually had it as a table written out in full on a whole page. And I understood that. I used to cross out each week and I'd go, okay, that day, that day. That was once I was ready to start returning to work. That was after about 14 months.
And that was the rehab provider, LTS? Or?
Yes, yeah. But all the way through those medical case conferences, everybody that was attending was listed the same way, their contact number, what their role was, and the outcome from the meeting. So even though I couldn't understand it, I knew it was there. So that written information was really, really important to me. And the verbal information was just about impossible for me to understand.
Yeah.
I just couldn't take it in.
Yeah.
She used language like, this is the projected number of days you return, or we anticipate your return. She didn't say you will return on this day and this day. She used really soft language, possible days. She used language like that. She never ever discussed my I have a lifelong mental illness. There was an initial contact with my treating psychiatrist, and he reported back that Jennifer has a lifelong mental illness. This has absolutely no bearing on her ability to perform her duties. And that was the end of that. The process, the return to work facilitators, everybody just let that treatment be.
Yeah.
And then but I still went to other psychiatrists for my employer who gave the same feedback.
Yeah, okay. So thinking back, I guess, on that initial return to work, what should have happened? I mean, I think there's something fairly obvious there. That person shouldn't have done that, or perhaps shouldn't have been there. But what if you could have gone back in time, what would that have looked like, your return to work?
Someone just had to stay with me. It was so simple. someone just had one of them, any person just had to literally stand next to me, say something like, let me walk with you, and taken me outside and just walked with me, and I would have been able to calm myself back down. But I had nobody. Yeah. So the fear came from being completely alone, and absolutely it is the most alone and afraid I had ever been in my life. And I had a schizophrenic mother that used to beat us up. Yeah. I was more afraid in that moment than I have ever been.
Yeah, okay. Wow. And in relation to your support people outside of the rehab people, you mentioned your husband. Did they involve your husband? Did you have the support of others, or did they just work with yourself?
They worked. My husband often would attend the medical case conferences. Yep. At first, he would come inside and just sit behind me, and then as the process went on and I felt more confident, he would sit outside. The case manager was able to identify each time she saw me if I was travelling well or not. So she would come into the doctor's surgery. This was really important. She would sort of look, I don't know how she did it, but she would, because I was trying to work it out myself, she would look at me and she could just work out so she'd say if I looked away or looked down and didn't give her eye contact, she knew I wasn't the best. So she would sit away from me and not right next to me, but she'd never sit facing me. Yeah. So she'd sit further away, and then we'd just go into the medical conference, often without talking. But if I was better, so if I looked at her and said hello, then she realised I was travelling a bit better. So she would either sit next to me and we'd talk about, because we both like gardening, so she would make a reference about the plants. There's a couple of plants that I have problems growing, and we would talk about those things. But she would she would work that out and respond accordingly, so that I didn't go into the medical conference heightened. I was always, I was just in the same state as when I arrived. She didn't make it any worse. And I think that's the point I'm trying to make, is the whole process, as complicated as it was, she never made it any worse. She also the other thing, she was a pure facilitator. So she took me through a process that's really complex. She never explained the process to me. So she would say, you need to go to a psychiatrist, you need to be at this appointment at that time. But at no time did she say, oh, you need to go to a psychiatrist because we need to have a check, because we need to do this and we need to have that, and this one will go there and that report will go. She just said, you need to see the psychiatrist at 9 o'clock. I didn't need to know the process. I wouldn't have understood it anyway. I didn't need to know what was going to happen after the next step. I just needed the next step, as small as it was.
Possible, yeah. Sounds like she knew you very well, and she knew very much what she was doing. So what a great support.
Exceptional, yeah.
So what happened after that? Did you ever return to work, to that employer?
I did. I returned for 6 months, and my colleagues did not speak to me the whole time. I decided teaching is all I've ever wanted to do, and I love teenagers. I love working with them. It was actually the case manager that said to me, you know, you've been to a pile of different workplaces and it just hasn't worked. Maybe you could think of doing something else. And when she first said that, I thought, there's no way that's going to happen. But she was the one that sowed that seed, and I really needed that. I needed to realise that unless I was going to change and go to another place and there was no guarantee that it would be safe, that I really did have to consider something else. And also, I suppose, the experiences that I've had in my life, I thought if I can share this in some way, it might actually really help and drive some change. I have absolutely no shame about what happened.
Yeah.
And
Yeah, thank you. I guess to sort of bring it all together, if you're looking back now, what advice would you give our audience? Some of them are the rehab providers like Altius. Most of our audience are representatives of the employer who support their employees to return to it. What sort of advice would you give our audience who are supporting someone in a similar situation? Just in summary, I guess.
In a summary, I'd say when you're talking to the person, be present. So just try and notice their physical reactions, whether they're agitated, looking away. Try to notice those physical things and respond to those. So, calming the person, not talking very much, sitting next to them, those sort of things. Stay non-judgmental, because we all have mental health, and people can get triggered by all different things, and people have all different experiences. Mental health, psychological injury is definitely not a sign of weakness. I don't know how many times I've had to bounce back from difficult situations as a child. It is definitely not a sign of weakness. It's just exposure to a situation without support.
Yeah.
And I'd say rely on facilitation, and realise that the process won't be linear for the worker. It will be a wavy line.
Yeah.
And I suppose I would also like to say that the job that case managers do saves people, and you're the link between the employer, the insurance company. You're like the conveyancer when someone's buying a property. You're the one that links the whole thing together, and the role is absolutely vital. My case manager saved me and returned me to a place of health, and I will always be grateful.
Yeah, that's terrific. And that's what led you to your own business, I believe.
Yes.
Is that what came next?
Yes. So I do two things. I've started speaking more about what happened to me. So I've become a speaker and I run workshops, but I also teach people with disabilities how to cook. So that's a very individualised approach. It always, it's always very challenging, and it's always very individual, and I absolutely love it. Yeah.
Yeah, and we're getting some great reactions there. I love the photos that you share with us today too, from your teaching days. So thank you so much. Your story and insights are very powerful for us to hear, and I don't need to say please join me in thanking you, because I can see that happening already.
Okay.
So really appreciate you coming along. You'll come back on later for our Q&A session.
Thank you.
But yes, thank you so much. You can turn off your camera and I'll see you again soon.
Thank you. Thank you, everybody, for all those emojis. Thank you.
Thanks, Jenny. I'd now like to welcome Simon into the discussion. So, Simon, if you'd like to turn on your camera. Great, that's working well too. Thank you so much. And welcome to today's forum.
Thanks, Kayleen. It's great to be here.
And when you're ready, you can take over control of
great.
Let me know if that works for you.
Yes, it has.
That's terrific.
That's great. Thanks, Kayleen. So as Kayleen said, I'm I guess here to talk about my clinical experience. I am a clinical psychologist. I've been practicing now for over 30 years, and in a range of different contexts as well. I've worked in the public hospital system, the private hospital system, but mostly in private practice. And it's in private practice where I see a lot of workers, and some of them are going through rehab claims as well, but others are perhaps in difficult work situations where they're managing bullying or managing issues around excessive workload and so on. And so they want to try to understand how to better cope or how to reintegrate back into the workplace. Before I get too far into it, though, I'd also like to thank Jenny for sharing her story. I think it illustrates so many points about these sort of scenarios that are critical to understanding how to help, and making yourself vulnerable like that and sharing a story is actually a very, very difficult thing to do. So it's very brave of her to share that story.
Yeah,
And
thank you.
and part of the reason why I've chosen this particular title for my part of the presentation today is, as you can perhaps understand from Jenny's presentation, going back into the workplace after you've experienced bullying provokes a lot of fear. There's a lot of concern about how you'll be greeted, and Jenny's example, I suppose, gave a really good illustration of just how bad it can be. And these stories get out into the community, and people understand that just because they're going through a process doesn't necessarily mean they can expect to be treated well when they get back, even though they should be treated better.
Yeah, of course.
Yeah.
So I imagine you're going to unpack, what happened in a lot more detail, but just to sort of start us off, from that clinical perspective, what was actually happening for Jenny in the brain and the body when, or for anyone that experiences trauma at work, and how might those symptoms show up during the planning return to work?
Well, fundamentally, what happened for Jenny was a fight or flight response, and she didn't need to have that background history of her lifelong mental health condition or the trauma that she'd experienced to have that fight or flight response. And I would hazard a guess that everybody else in that room, in that initial scenario, had a similar sense of anxiety where you get a rush of adrenaline, and then you get a cascade of physiological symptoms that occur to you. And in Jenny's case, it triggered memories, but that in itself is just a unique feature of her case. But of course, the behaviour is unacceptable. So I just wanted to. Sorry, did you want to ask?
No, I was just going to say
No.
thank you, and I'll leave you to
Okay.
do your presentation.
So I'm quite sure all of you are familiar with what bullying is, but I just wanted to recap it very briefly. And just to sort of highlight the difference between overt bullying and covert bullying. What Jenny experienced was very much the overt, the aggressive behaviour, shouting, spitting, humiliating, those kinds of things, criticizing in public as well, in a very destructive, aggressive way. They're all, I guess, there's the types of bullying that most of us would think of when we think of perhaps schoolyard behaviour, but also common workplace behaviour. They're the things that play out over and over again. But overt bullying also exists, and it's also important to keep that in mind when you're thinking about returning people to work. And that's things like social exclusion, so intentionally leaving people out of a group. And Jenny experienced that when she tried to return to work, and people not talking to her was also bullying. Spreading rumours, manipulating relationships, deliberately interfering in friendships and collegial relationships and that kind of thing. Subtle or disguised insults, so whispering, backhanded compliments, things that might seem innocent on the surface. Excessive criticism, excessive supervision, taking credit for somebody else's work. And many of you have probably heard the term gaslighting, which gets used a lot at the moment, which is manipulating people into questioning their own reality. So making them feel like they're at fault, perhaps, when actually it was somebody else, and usually the bully, for that matter. So they're all significant behaviours, I suppose, that really undermine a person's sense of self, their confidence in their position in the workplace, and their sense of safety in the workplace. And of course, what's not bullying is reasonable management action. So it is obviously appropriate at times to provide feedback about underperformance. It is necessary at times to put people on performance management plans and so on. That's all perfectly reasonable. The only thing I would say about that is that it has to be done appropriately. So it has to be done in a considered way, in a supportive way, because it can be perceived as bullying sometimes when it's not, and that's something I might talk about later on. But it also can become bullying if it's done badly. So the psychological impact, to your point, Kayleen, is that that cascade of anxiety that happens. So whenever we're put in a situation where we feel threatened, the first thing that happens is we release a surge of adrenaline, and this is an evolutionary response. It's something that's been bred into humans over tens of thousands of years. So it's something we don't have any direct control over. And for some people, we experience that reaction more strongly than others, and there are biological reasons for that. But what happens when you release adrenaline is you get all of those symptoms. You might feel a sense of nausea, your vision might blur, you might feel your heart racing, you might feel your legs go wobbly or your arms go wobbly, you might feel your breathing pattern change, you might start to sweat, you might feel like you need to go to the toilet. All of these are what we call signs of the sympathetic nervous system being aroused, and they're preparing us to deal with whatever the threat is. So if you think about a traditional fight or flight scenario, you've either got to attack the threat or run away from the threat. And people do respond differently in these situations, and that concept of fight or flight has also been expanded now to fight, flight, freeze, or feign. So sometimes people, particularly in violent situations, freeze up because they don't know what to do, and sometimes people fake what they think is needed from the response. So this is perhaps more common in scenarios of domestic violence, perhaps where people do what they think their partner wants them to do, and that might be being sexually submissive, for instance, because that is the way to keep themselves safe. So they know that if they just do what's expected of them, they're less likely to come to any sort of physical harm. So with respect to safety, survivors of bullying who have needed time off work feel afraid that the bullying behaviour will be repeated, that it might be amplified, that there might be some kind of retribution when they get back into the workplace. And they're also often afraid that the people and the systems that were supposed to keep them safe in the first place will fail again. And if they've had a bad experience of bullying, bad experience of support regarding the bullying, those same feelings will be amplified more, and their trust in the whole organisation can be severely compromised. It can lead people to feel stupid or worthless. It makes them question whether they have done something to deserve the behaviour. If they've had childhood experiences of being bullied, it can reignite those emotions. If they're experiencing domestic violence, or if they've experienced some other trauma, as was the case of in Jenny's situation, they will have less capacity to cope. And in mental health, we talk about the fragility of people. The more traumatic things that have happened, the more illnesses they've experienced, the more likely it is that they'll respond poorly under pressure. But also there's sort of current issues. They might be under huge workload. There might be domestic pressures. They might be looking after small children, or looking after aging parents. They might be experiencing relationship challenges or financial pressure. All of these things have a bearing on somebody's capacity to cope. So this gives you this is just sort of going back to what I was talking about earlier. That's I suppose the critical part of the brain that's affected is the hypothalamus. And that's the part of the brain that is connected to the release of adrenaline. And there's the hypothalamus and the amygdala work together to create that biological response. And that's not something that we have control over. So it's an involuntary response. And so sometimes you'll hear people, well, again, to Jenny's point, she was told she just needed to be tougher and suck it up, basically. It's not something she had control over. So as far as the return to work process goes, this is always a difficult scenario, and it's difficult for clinicians as well, because how long is a piece of string? What's going to happen along the way of this, for this person to return? Creating awareness, I suppose, working with the worker to understand that everybody knows that this is not a simple process is really important. It validates their experience, because they'll be feeling uncertain about what they're capable of. They'll be feeling intensely aware that they don't feel safe going back into that workplace, and they're not sure of how to re-establish a sense of safety. And from the therapeutic process point of view, we are working on things like their anxiety and their hypervigilance. We're sort of looking at unresolved trauma, underlying mental illnesses, perhaps all of those things that need to be addressed, not necessarily need to be resolved, but need to be part of the process of getting a person ready to return to work. And where your role as a rehab provider is really important, is helping to rebuild trust and rebuild confidence that when they go back to work, they'll be safe. It's that sense of psychological safety that's so incredibly important. So the process of rebuilding trust involves really good, clear communication and pacing the process of rehab and returning to work with where the person's at. And for some people, they'll take, I suppose, a period of time to get to a point where they can even contemplate returning to work. For other people, they'll be able to contemplate that sooner. And you can gauge that to some degree by the severity of the symptoms. So if you are trying to set things up to succeed, I suppose the listening process is one of the really key processes in this whole return to work scenario, that you need to be able to listen empathetically. You need to be able to investigate, or you're not doing the investigations, you're doing the rehab and the return to work, but you need to be in mind about what the challenges are with that return to work. You need to be able to be mindful of the conflicts of interest too, of who's telling you what, and I would include the practitioners sometimes in this too, because some practitioners are conflicted. Some practitioners feel too aligned to the patient and or to the worker, and that you need to be able to try to engage the practitioner in helping the worker to feel safe to return to work. And you also need to be mindful of the feared impact on the person's career. So they very often people will think, I've got to be able to return to work, I've got to be able to overcome this, and they're not necessarily thinking about what is the best way for me to return to work and what's the best way to do this safely. One of the challenges I often see people experiencing is that contact during time off, the initial contact. It was very clear with Jenny's case that she had an excellent worker who made contact early on and established how they were going to work together. That's not always the case. I've seen lots of scenarios where workers haven't been contacted. They haven't been contacted by their workplace. by their manager, by any kind of return to work coordinator. I've had one person recently who lodged a claim in March last year, and the first they heard from anyone from work was in December. It's just mind-blowing that they could have been left that long without any kind of contact or support. The contact, but once you have established that kind of contact, really being clear and predictable about the way you're going to communicate and the way things are going to progress is important. So it's important to not promise things that you can't deliver, but also if you have made a plan to work with the person in a certain way, to contact them at a certain time, if for some reason that becomes impossible, if you become unwell, or if you change, if you're changing jobs, if you can hand that over or communicate back to the person, that's really important to keep them in the loop about what's going on and how they're being supported. And that's really key to building trust. Clear, predictable communication, communication that's sort of focuses on what can be done and as well as what can't be done. They're both really important aspects of the communication. And of course, making sure in that communication that you're prioritizing psychological safety, that you understand that the safety is being compromised in that situation, and that you understand that things need to be done to give that person confidence that they're going back into a safe workplace. And so the timing of the return to work really should partly centre on when the worker feels a sense of control. And when I say partly, I say that because it's important not to be too passive in that as a case manager, and to try to encourage the person to think about returning to work, because we all know the faster a person gets back to work, the better the outcome. The longer they sit at home and stress about what's going to happen next, the more complex the problems become. So engaging with them early, talking to them about a pathway, making them feel safe, are really important steps in getting them back to work, but also taking it gradually and recognising with them and with the workplace that the worker needs to re-establish a sense of trust that when they're at work, they're safe. And the best way for them to establish a sense of trust is to actually take the step and go back to work, but to do it in a planned, considered way. And then to review it, of course. So as their coordinator, to check in with them and see how it went, what went well, what didn't go well. Is there somebody else that needs to be involved? Is there more communication that needs to happen to smooth the way so that the next day or the next week they have at work is better than the first one? When it comes to the trust, Kayleen mentioned at the start that's the distrust and the fractured relationships that are really difficult to overcome in these scenarios. And really key to re-establishing that trust is acknowledging that harm has been done. You're not going to make any progress in a scenario where there's a denial that there's any harm that's been done. Being the victim of bullying is being harmed. Validating their experience, and then clarifying the purpose of what you can do with them, talking to them about that safe return to work, how that process is going to happen, how you're going to be involved, and who else is going to be involved, and then asking about their needs in the process, what would help them feel safe. Are there any work situations they'd prefer to avoid? What types of tasks feel manageable at this stage? And that's really important too, because you need to, I suppose, put them back into a scenario where they're doing meaningful work. And I'll talk about that a bit more in a moment. Take them through the return to work structure and be as kind of clear and transparent as you can about what a return to work looks like, and that that it's not a dictated process, that they're involved, they collaborate, that their health practitioners are involved as well. It's not linear. And so, back to that earlier point about how long is a piece of string, we have a plan of how things should work or could work, but we have to try to implement that plan and step people through it and see how it works, and then reevaluate and reiterate. Okay, and just also in terms of being transparent and consistent, defining the way you're going to communicate, when you're going to communicate, how you're going to communicate. Are you going to does the worker want a phone call, or is a phone call going to be too triggering? Would they prefer an email? Would they prefer a text message? So establishing with the worker what kind of communication works best, what time of day works best as well. Particularly early on, if they're very unwell and their sleep's disturbed, they might sleep in. They might not really be available to be contacted in the mornings. I've got a worker at the moment who has chronic fatigue. She struggles to get out of bed before 11 in the morning, and yet her caseworkers keep trying to organise meetings for her at 9 in the morning. It's there's a lack of understanding in that situation about what the worker's needs are. And in doing that, in having those kind of two-way dialogues about that, you reinforce I suppose the realization that they have some control and they have some influence in this process, which is really important for them to feel like they've been given back some control. I'm just mindful of the time, so I'm going to skip ahead a little bit. I mentioned meaningful work. I think for most of you that will be fairly obvious that you don't want to be giving somebody who's done very high-level work that's too basic for them, and you ultimately want to aim to get them back to the same role and the same duties. That might not be manageable, just depending on the nature of the bullying and whether the workplace can be made safe again. And if they can't go back to the same role, then finding something that's of a similar complexity is really important. So I guess the other thing is managing sensitization and triggers. So identifying what the triggers are as well. So in Jenny's case, for instance, the triggers might be the individual, it might be the other people who are in the room, it might be the location where it took place. And because of the complexity of Jenny's situation, it could be other things that were connected to the initial trauma that she remembered. It might be exclusion as well. So Jenny talked about walking past people and nobody helping. She talked about coming back and nobody talking to her. Feeling like you're being excluded can become a trigger. And think about alternative workplaces or workspaces. So one of the ways of reintroducing people gradually to work is now with working remotely is quite a good way of enabling people to get back to doing the work without necessarily being confronted by the people or confronted by the place. And when I talk about training managers in trauma-informed behaviours, it's things like speaking gently and respectfully to people. It's things like regular check-ins on their comfort levels, like how are you going? Asking those very normal human questions about whether somebody's coping or not, and provide choices if you can. So try to, if somebody's saying they're not coping so well, to talk to them about, what do you think would help you cope better? What would help you get through your day at work, or help you manage that person or that situation better? And don't be dictatorial or authoritative. Don't tell people what is going to happen. If you can possibly avoid it, talk to them about what could happen and how they can influence the whole process. Again, I'm conscious of time, so I'll skip one or two.
We're doing okay for time.
Yeah, okay. Okay, so include the regular structured check-ins, but talk beforehand with the worker about how regular those should be. So it's a collaboration, I suppose, between what you think as a rehab coordinator is going to be helpful, but also what the worker can cope with. So ideally, you might schedule a weekly check-in, but the worker might say, actually, weekly's too much for me at the moment. I'm not doing so well. I need it to be 2 weekly or monthly for a little while until I start to get my mental health back under control. Ask open-ended questions about their things like their workload, their interactions with other workers, and barriers to returning to work. And invite them to talk about their concerns without judgment. So it's important to really let people complete their thoughts when you're talking to them, to let them get to the end of their sentences, and even to leave a bit of silence as well. So you've given people space to think about what's happening for them, and that silence also conveys the sense that you're listening to them, that you're not just waiting to speak, waiting for them to stop speaking so you can jump in and say something. So be quite measured about the way that you speak. And then, of course, adjust the plan as necessary. And I kind of touched on that with the frequency of contacts, but that might also include the start date for a return to work. You might pick Tuesday next week, but between now and Tuesday next week, something else might happen. And it doesn't necessarily have to be connected to the workplace. But, if that worker's contracted the flu, or their parents died, or their cat's in hospital or something like that, those factors are important, and showing some compassion for those things is important as well. We can, I think, if you can include the clinicians that are involved, that's very helpful. And just understanding that when a worker's returning to work from any particularly mental health related issue, they often feel broken, and they need the input of health professionals. And the health professionals help to bridge the trust as well. So the health professionals can actually be a useful conduit for you to talk about, this is what we're trying to achieve. Can you help us with, understanding what will help that worker get back to work faster, or what's the best outcome in this scenario? And often health practitioners, psychologists will actually sit with the client and sometimes challenge the way they're thinking about it, challenge the kind of anxious thoughts. It's our role as practitioners to do that, but we've I suppose got more space to do it because we're not perceived to be part of the problem. We're not part of the workplace. So we've got a bit more license to be challenging in that way. But as part of the trust building process, it's seeking informed consent before you contact providers, and including the worker as much as you possibly can in that communication. And providers are also quite mindful of that too, about talking to the worker about what kind of information they want shared back with the rehab coordinator. One of the other things I wanted to touch on, and particularly with the new legislation around psychological safety at work, is that it has to be safety for everyone, no matter what. And again, Jenny's scenario kind of highlighted that you never actually know what's going on for somebody. Even Jenny didn't remember those past traumas. So if she'd been asked beforehand if there was any significant past trauma, she could have, in all honesty, said, no, there was no past trauma. I can't, because she couldn't access those memories. But even if she could, that's not information that she is required to share in the workplace. And aside from trauma, there's other sort of mental health issues. There's anxiety and depression, which are incredibly common. You're probably mostly aware that at least 50% of the population will have mental illness at some point in their life. The prevalence of domestic violence in the population is enormous. So I think it's about 1 in 4 women has been or will be sexually assaulted, which is a horrible statistic, but it's the reality of the world we're in. And then there's just workplace pressure, financial pressure, cost of living, as I said before, looking after aging parents. There's all these other pressures that are going on for people, and the workplace has to be safe for all of them. And if people treat each other with respect and professionalism, then it shouldn't be a problem. So it needs to be a place where people can speak up without fear that there's going to be retribution. Workplaces need to encourage that kind of respect and inclusion. And I use the word inclusion thinking also of cultural inclusion, gender diversity, those kinds of issues as well. And the workplace, the obligations on the workplace to explain, to provide, and to be proactive about mental health have just increased significantly in the last few years. And workplaces have to be much more proactive now about identifying psychosocial hazards and managing those hazards. So I'll leave with that thought, that it's not just about getting back to a role. It's about feeling safe in that role, feeling trusted, and being able to hold yourself out as the worker or the professional that you were beforehand, and feeling safe in that environment. And if you can do that, I'll skip to this last slide. It's no longer returning to the lion's den. The workplace is tamed, and hopefully the worker feels much more comfortable about returning into that workspace.
Wonderful. Thank you, Simon. Keep your camera on, please. I can see that the presentation has resonated with our audience, with the reactions there, and we have had a few questions come through. So Jenny, if you would like to turn your camera back on again, and I'll just go through some of those questions that have come through. We've got about 20 minutes, give or take 15 minutes maybe. So one that you were just talking about, I think relevant, Simon, for you is Marie talked about, it's good to hear your perspective, Simon. How do you suggest workplaces can prepare colleagues and the manager for an employee's return to work to ensure the employee feels supported whilst also maintaining their privacy? So you were just talking about that, but how can they do that to make sure that, I guess, the colleagues and managers know enough?
It's a complex question because it depends on how many people have been involved in the absence from work and how many people know about what's going on. It's important, first of all, to talk to the worker about what they're comfortable with and to try to facilitate some sort of meeting, I think, with key people involved. So generally, if you can facilitate a meeting with the manager beforehand and talk about what the issues are and how that manager can help that person feel safe in that context, that will go a long way to getting them back into the workplace. And, brokering those conversations helps the worker overcome that initial anxiety. As Jenny talked about, having somebody walk with her, that's kind of a way of facilitating that that process of getting people to walk together to get them back to work.
Yeah, and I guess, Jenny, that for you was your rehab provider that you talked about and the support you had from the insurer as well.
Yeah, absolutely. Yeah, they were key.
Yeah. Thank you for that question. Petra has asked, and we actually were, this came up quite a bit in the registration questions as well. So often you will have a situation where there's an unsubstantiated claim of bullying, or there's been a finding that there wasn't bullying, but the person still has an injury following that. They may even have an accepted claim because they're two different processes. So how does this intersect with acknowledging the harm? Perhaps if the claim has been unsubstantiated, but you want to acknowledge the harm, and how that type of approach impacts on the person who's been accused of bullying as well. I guess that's quite a big question.
Yeah, it's a very big question. Look, I think when it's been found that the harm, that the bullying didn't occur, you've got to consider actually, whether it actually didn't occur, and whether, because the other possibilities are that it was so covert that there's not enough evidence that nobody else can substantiate it, or that it did occur but the other witnesses feel too intimidated to provide evidence to corroborate the story. So I think if you can organise mediation, to have some mediated discussions with the people involved, to try to get them on the same page, and that process then, in having that process, hopefully you build a sense of trust with the worker that they're going back to a safe environment. That kind of mediation and communication is really important if it's possible. It may be, though, that the worker feels just too unsafe to return to that workplace, and it's their experience that it's just not a safe place to be. But you have to be mindful that it could be any one of those three things. Just because the investigation said that it didn't happen doesn't mean that there's not a possibility that it has happened. Also, I think one of the things I find is that investigators or workplaces sometimes say, well, they're clearly their reaction is disproportionate. Clearly, this is not on us. But again, going back to that comment that it has to be safe for everyone. The workplace has to be safe, no matter what the worker brings to work. Whether they might be depressed, they might have bipolar disorder, they might have they might have an underlying post-traumatic stress disorder. In that context, that reaction is not excessive. It's they've been triggered more easily. Yeah. So
yeah, keep going, please.
That's okay. There was another part to that question. Sorry, mentioned.
Is it still up there? And what type of, and the approach with the accused as well, how that impacts on the accused.
The impact on the accused. Yeah, look, that's a really important thing to consider, because particularly in scenarios where there was no harm intended, if somebody has done something that's caused offence, they could be just as distressed about the fact that the offence has been caused, and that they're now the subject of some sort of investigation, that the finger's being pointed at them. So this is also where that kind of mediated conversation can be really valuable, because it gives the inverted commas, the bully, the opportunity to talk about the fact that they understand now that they've caused offence, and they've caused distress, and that wasn't intended, and that can be very valuable in healing as well.
Would there be some circumstances where, obviously both parties would have to agree, but where perhaps it's just not safe?
Absolutely.
Yeah.
Can I say something to that as well? Just that in my case, everybody across the workplace knew that my manager was a bully. So she micromanaged literally when every time myself or another woman got out of our seat, and I mean every time for 5 years, she asked where we were going. And sometimes I said, I'm going to the toilet. but every time she would ask, she was known throughout the school, and people had moved into different faculties and things to get away from her. When she first, when the incident was first brought to the attention of her manager's response was, oh yeah, she does shake when she screams. And her other response was, we have a policy in place that protects everybody. So the two responses sort of indicated that they did have real problems with managing people. Yep. So in that sort of mediation process, I can see that those sort of, like, it sort of gives both parties a way to express what's gone on, and it's the responses, I suppose, or the evidence that comes out that sort of leads to the truth, I guess.
Yeah. Yeah. And I'm also thinking about those circumstances where it really just, person, maybe it's not appropriate that they return to that workplace. That's very challenging in our scheme. I'm sure it is in other workers' comp schemes, because it's not always possible to find something, or for there to be something available outside of that employer. But we do have a question about the best way to manage a situation where the GP places a blanket ban on returning to that same employer, and we do see that a little bit because, of course, they're supporting their and advocating for their patient. In many ways, I understand that they do need that advocacy, but there might be the opportunity for redeployment, or perhaps to support the person. We've got some big employers in our scheme and big government departments to actually support them in a different area or a different division. So I guess the best way to work with the GP and to best manage that risk. Any comments on that, Simon?
Yeah, look, I think the first thing I would do is try to set up a conversation with the GP to try to understand what the blanket ban is about, because there may be very good reasons for that. It might be that the kind of trauma reaction, I suppose, is triggered by entering a particular building, or it might be that it's the whole workplace, particularly if the bullying has been going on for a long time, that whole workplace has become tainted, that the worker has reached a point where they're convinced that there's no way that they can be kept safe in that workplace. And Jenny, to use you as an example again, the fact that somebody would say she shakes when she yells, says that this is a known problem. This is something this person does commonly enough that the people who manage her know that she yells, first of all, and that she shakes when she yells, and that they've done nothing about it. So they haven't made the workplace safe. So engage with the doctor to find out whether there's any way at all that the workplace can be made safe, to understand why that blanket ban is there. I think sometimes health professionals get a bit time poor themselves, and they perhaps get pressure from patients as well to say there's absolutely no way I can return to that workplace, and they, because of the time pressures on the practitioner, they don't necessarily have time to explore it. But I'd also, if possible, if there's a psychologist or a psychiatrist involved, I'd try to work with them to understand, because they'll probably have a better understanding of the nuances of the situation that might be helpful.
Yeah, thank you. We have a few questions there which are more about, there's a few similar ones where the employee is just not engaging at all. It might be with the workplace, or it might be with that rehab provider whose job, they've been engaged to work with the person, and they're just not getting anywhere. They're not getting any contact with the employee at all. I guess there's not a quick, easy answer to that, but any comments you'd like to make on that, either of you two?
I think for me, what happens when I'm really unwell is the phone is a real trigger, because I don't know what's going to be on the other end of the phone. So I would allow the case manager to call Tim, and so they would call my husband, and and the messages would come through him. They needed to anyway for understanding. So I don't know if going through someone else. And going on what Simon was just talking about with the talking to the psychologist about what specific things need to be in place. My eyes were wide open that my workplace was unsafe, but 3 strategies were put forward. One was that I sat in a different place, which wasn't accepted by my workplace. Another was that I wasn't to be screamed at, which wasn't accepted by my workplace because they said they had a code of conduct that protected everybody. And the third was that I would have a staggered return, which, because that was part of the return to work process, was allowed. So my eyes were wide open, but I still was determined to have the strength to go back.
Yeah, thank you. Let me just see, what else do we have here? Situations where duties have in line with their employee's capacity and their restrictions can't be identified with that employer. How do you think when do you think it's appropriate to discuss the goal of return to work, such as external employment? I mean, imagine it would be case by case, but that can be quite a difficult conversation with an employee because they might see that you're trying to edge them out of the organisation. So how do you approach this with the employee, but also with their treating practitioners?
I mean, you're probably getting to the end of a process when you start to get to those kind of questions about alternative work, that you've tried all these other approaches and that nothing else has worked. I guess one of the ways I'd approach it with the worker is to actually reflect back and say, we've been through this process. These are the things we've tried. Is there anything we haven't tried, anything else you can think of that might help you get back to where you were? So you're trying to get them to the point where they say, no, I can't see how there is anything else, any other approach perhaps that would work. And then that gives you more permission to say, well, what about something else?
Yeah, and I think I was about to say, that's, I guess, in some ways what happened, Jenny, is you did eventually go back there, and then there was ultimately that decision that it was best to move on.
Yeah, I was determined to go back. I was absolutely determined to go back. I was not going to give up my job as a teacher. I love the students. I was an excellent teacher. I wasn't prepared to give it up. And so I really fought hard. But for me, the joy was gone. So it hurt, and the joy was gone. And it was sort of, I'd had 2 days back in the following year. I had my computer and my keys in my hand, and I was looking around the room to see who I could actually give these to that I trusted enough that they would not steal them. And I was well by this time, so that they would, when I say steal them, that they would not admit that I'd handed it to them. Yeah. Because these are the sorts of people I was up against. So I found someone and I handed it and I said, that's it, I'm done. Can you take those off me and I won't be back? And the person sort of looked at me and just said sorry, and that was my last day.
Yeah. Did you, I think we'll finish on this, did you get to say goodbye to your students?
I did. So I actually live in the area where my students are, and I often run into them, and I'll be in the middle of a shopping centre and I'll hear Mrs. Chate, and when that happens, like other students, so they have been very gracious in their I suppose in the comments that they give me, and they've actually been very, very gracious. Yeah,
I'm very pleased to hear that. So thank you both so much for sharing your insights and experiences. I've learnt a lot today. You've helped us see just how complex these cases are. I think we knew they were complex, and that is absolutely confirmed. And reminding us that, that recovery is not a straight line. It's sometimes the safest and most supportive thing we can do is to slow down, listen, And I guess I give that person space for healing. So thank you both for your time. Please continue to thank our wonderful speakers today.
Look at all the, I'm thanking them too.
Lovely.
Yes, thanks for your interest.
That's really lovely.
Keep your cameras back on because we've only got 2 more minutes. So ComCare's National Conference is our flagship event, which happens every 2 years, and we have exciting news to share that the next conference is confirmed for the 14th to the 16th of September next year in Canberra. It will explore a people-first approach to workplace health and safety. So more details will become available on the ComCare website. And I'd also like to unashamedly wish ourselves a happy 5-year anniversary. We've been bringing you these forums for 5 years. Because of COVID, we all started to look at how we could engage in a different way. I must say it's one of my very best favourite things I do in this job. And we had no idea what we were doing 5 years ago as far as the technology went. But, you know, really they're as good as they are because of the wonderful speakers that we have come along, and also because of our wonderful audience. You keep coming back, the numbers get bigger every time. So we thank you so much for supporting us in this, and for telling us, you know, ideas for topics. That really helps us. So I'd like to wish you all the very best for the holiday season, whatever you're up to. Continue to do the great work that you do. We do understand that it's complex and it's hard, and you're all out there doing your best. So have a safe and happy festive season, and we look forward to seeing you all at our next forum in 2026. Thank you and happy holidays.